Pratt Chavez. She's one of my favorite people. She's a really, really good speaker and is very passionate about what she does. Heather went to medical school here and then she completed her residency in pediatrics here at UNM. And currently she is an associate professor of pediatrics at the University of New Mexico's School of Medicine. And she is a general practice pediatrician. She is also the medical director of our Focus Pediatrics program, and she is the director of the NOW's New Mexico program, which enhances care for neonates with opiate withdrawal syndrome. So please welcome Dr. Pratt Chavez, and she's going to be speaking to you today about our little babies and what they need from us.
Hey there, thanks, Kathy. I'm really happy that I get to follow right behind Sevi because I feel like our talks have a nice continuum of the timeline of care for families who have a new baby in the setting of opiate use disorder. So I'm going to share my screen. Okay, so I think it's really nice that Sevi could talk about what it means for a pregnant woman who has a opiate use disorder to get started in treatment and to start her care for her substance use disorder. And then she talked about the issues around labor and delivery and some of the postpartum care that women need in the setting of opiate use disorder. And so now we're skipping over that inpatient section of time when babies have to be hospitalized and occasionally moms have to be hospitalized in that early postpartum period. And I wanted to sort of step over that little section of time into what the long-term postpartum and long-term care for babies and families who are dealing with the social and structural determinants of health, especially opiate use disorder. So I'm going to be talking today about what we do at the Focus Clinic at UNM Hospital. And I'm the medical director of this program, especially the pediatric section of this program. I'm also a general practice pediatrician, so I take care of babies and kids in lots of settings in the hospital. But I really wanted to tell you all about what the satisfaction and the challenges of taking care of families in the Focus Clinic is and why I like it so much. Our objectives today, I'm going to talk about, I'm going to use a case, and this is actually a case that we just had a few weeks ago in the Focus Clinic, and to kind of talk about what the continuum of care is for families and what services we offer, because I think it can be confusing, but if you can attach it to what a family experiences in this program, then I think you can see what the components are. And then you can also see, hopefully, how you might be able to do some of this work in your communities. And for me, the services that we offer and the interaction with this family really shows where the stress points for us as providers, like what makes our tummies hurt when we're taking care of families in this setting, and what do we worry about, and how can we make it better. And then I'll try to go into a little more detail of the definition of the services. I'm so glad that we've already had some discussion about the home visiting services, because I want to talk about where that fits in this care plan for families. And then how we can avoid just having these siloed programs. I don't know about you guys, but I hear like these names of programs all the time that have like these charming names: Focus Clinic, Milagro, and what does it mean, and how do they interact? So I want to talk a little bit about that. And then what I think really makes Focus work and how you guys can do that in other communities. It is a resource intensive kind of program, but there are ways that we can bring those resources to other areas of our communities. And then I'll talk about what groups are in the Focus Clinic. And then at the end, I have a request for you guys in the audience. And so I hope you might be interested in being in a study. Okay, so here's the case. And this happened to us just a few months ago, actually about a month and a half ago. So we are holding Focus Clinic at the Southeast Heights Clinic, Family Medicine Clinic in Albuquerque. It's really busy. There's lots of hustle bustle. It happens to be a day when the Milagro Clinic, so Dr. Goudelet's prenatal and postpartum clinic, is co-occurring at the same time in half of the clinic, and then Focus Clinic is in the other half. So there's a lot of action. And then I have a brand new intern working with me. So they're a brand new doctor doing some of their first patient interactions that they've ever had by themselves, like saying, I'm your doctor. So that's like an emerging setting there too. And we see on our list is this patient, a little 2-week-old baby who was discharged from the hospital 2 days ago. The baby had prenatal polysubstance exposure, was treated for opiate withdrawal in the hospital with morphine, and then discharged in the care of the maternal grandmother. So I say, okay, intern, go in there and let's get started with this case. So the intern is in there for maybe, not very long. And then she comes back with her eyes like that. And she's totally, clearly overwhelmed. So she says, the mom and the maternal grandma are present in the visit. And there are lots and lots of questions and lots of emotions flying around in this room. And so I don't know if this setting might ring true to any providers who have patients who have prenatal opiate exposure, because there's never just a little baby. There is a little baby and someone. And so when there is a little baby who's exposed to substances, there is emotion and pain and trauma for whoever is there with that baby. So I follow the intern into the room, really, and sort of when we go in and try to assess what the core questions are about the baby care, because we think, okay, yeah, we're here, we have our little narrow picture, we're going to just take care of this little baby who's from the hospital, just out of the hospital, and let's do our baby primary care. So we try to sort of direct the visit that way. And grandma has questions about the baby wants to feed all the time. She's feeding, sometimes up to 6 ounces of formula, and the baby's spitting up. And so there's like a lot of questions about how to feed this baby who's little skinny guy who's kind of a little irritable. He's a little tight and he just wants to suck all the time. Meanwhile, the mommy is there in the room because her Milagro appointment was co-occurring at the same time. So she was seeing her postpartum providers and at the same time as the baby. And so the grandmother had agreed that the baby could be in the room with, the mom could be in the room with the baby's checkup, which was already kind of fraught, that we had to do this sort of delicate permission to have all the care people in the room. Mom is very skinny. Her hair appears like someone has shorn it off in a unprofessional way, shall we say. So it's really chopped and ragged. She is just crying. She is sort of pacing around the room. She doesn't look well. She looks like her skin is sort of has that grayish color of somebody who you feel like they're not healthy. She's saying, I just feel so guilty. I can't believe what I've done to this baby. I'm so sorry for him. So the little tiny baby's sitting there on the table. Here's the mom. We're all in masks too, so it's very difficult to sort of connect emotionally. And the grandmother is flat in her affect and is saying, I don't understand your choices. I don't understand how you can do this. And the mother's saying, you don't understand what addiction is like, Mom. You don't know what I've been through the last 4 years. You cannot imagine what I've been through. And of course, I think we all can have some idea of what a woman who is having active use disorder, who doesn't have stable housing, who got pregnant in active use disorder, clearly there's a lot of trauma. We knew from the record that there was some intimate partner violence. There was and a lot of trauma around her delivery. We also knew before we even went in that she was not in remission of her substance use, although she was going to appointments with Milagro and asking for help. So we go in and, whoa, right away, I don't know, I'm maxed out, right? I've got a few little tools that I can use, but to say, okay, you guys have already made some good choices here. The baby's here. Let's focus on the baby. But there's there's all the complexity of being a parent, the grandmother, parent to this woman who's struggling and in pain. So that there's the grandmother's pain, there's the mother's pain, and then there's little tiny baby who's just trying to deal with all of this too. So I'm like, I'm worried about the baby. I'm worried about the grandma and her flat presentation. Of course, I'm worried about the mom. The mom is very complex medical and substance use disorder, all of her medical issues of being postpartum as well. And then meanwhile, I know that I have, this is the first patient of the day. I have my trainee and I have to keep moving. So if I was like, okay, just feed the baby less and bye-bye, we'll see you next time. This is a case that would be bothering me through the night. I would feel like I wasn't really doing the best care for this family. And I have a feeling that a lot of you can relate to this moment where there is a lot more happening than just our little question about the baby feeds in this visit. And how are we going to take care of this baby when there's so much emotion and complexity and history happening? And so that's why I really am so happy and proud to be part of the Focus program, because we can bring in the right team of services and serve families well and serve the whole family unit along with the baby. And it's improves the outcomes for families, but it also improves the satisfaction in all of our work, because we all know that families and kids in our community who are at this high risk deserve our best care and our quality care. So it really is also about satisfaction and longevity in our work as well. So now I want to talk about kind of what we have in the Focus program. And I'm going to trace this case that I introduced to you throughout this talk. So we'll come back and I'll let you know sort of what the family is experiencing by being enrolled in the Focus program. So the Focus program kind of has two big circles of professionals that are part of the program. So the first circle I'm going to talk about are the medical teams. It's multidisciplinary medical teams. So we have the pediatric primary care providers, and that is provided with the family and community medicine attendings. We have 5 folks who are the providers from family and community medicine who are excellent primary care for pediatric patient providers. And we support family and community medicine residents and trainees in that setting. So we precept a number of residents and support them in learning primary care for this population of families. And then I'm the pediatric attending. Currently, it's just me doing the exclusive pediatrics, and I am coordinating care for some of the more medically complex babies and families who are in the program. So little babies who have G-tubes and cardiac diagnoses and things like that. I also support my colleagues in that care. So I think it's always better when we can help everybody be really good at giving complex pediatric care. So then I also have pediatric residents and trainees who I staff families with and who take care of the babies with me. So then we also have adult primary care. So the family and community medicine attendings and the residents provide the adult primary care for whoever is with that baby. So for instance, in the case we just discussed, we can offer care for grandmother and for mom in that setting. Then we also have psychiatry support. Especially connected to our program is the perinatal psychiatry attending and fellows who are available for consultation and care for these families. So those sort of is our core medical, our MD care team. And then the other circle of care, and I took this slide from my colleague Karen Longnecker, who is the program manager and also social worker and a provider of infant mental health services. So she made this little interaction circle here. We serve families in Bernalillo, Valencia, and Sandoval counties. And so the early intervention services include developmental instruction. We have occupational and motor therapy, speech therapy. I think really importantly, we have case management and social work. And then we have folks who are trained in infant mental health and can do ongoing long-term therapy for infant mental health. Then we also have a circle of security parenting group and curriculum, infant massage, and we are advancing more and more with our feeding support. And so you see there's the arrow of exchange between our medical services and our early intervention services. And I should make it clear that when I talk about the primary care for adults, we are because this does remind me to say that we do ongoing medication-assisted treatment with Suboxone or Subutex for families in the clinic. So our providers are able to do that treatment. We also collaborate with the ASAP clinic, which is the methadone clinic. So they are part of our team of medical services care. Okay, so then I wanted to come back to our case with the mommy and the grandma and the baby. And I was thinking about how I was reviewing the mom's chart and the discharge of this little baby. And I think about myself when I'm in the hospital and I'm getting ready to discharge a little baby in this circumstance. And maybe mom has been in through the hospital, maybe she hasn't. And we've called CYFD because we knew that mom was having an active use disorder and we wanted to make sure that the discharge plan was safe. And of course, CYFD just is our acronym for Child Protective Services, because I know we have some attendees from out of state. So Child Protective Services is our CYFD program. So they had screened out the case and they said that, that the grandma was going to be taking the baby home as the safety monitor. And so we often feel really stressed at this discharge point. This is when we get anxious because we feel like we're just sending a little baby off into the ether or into I don't know what, and we wish that we could control and make sure everything was okay for that baby. And so we have all these questions. Who is the baby? What's the baby's home actually like? Where are they going to be living? Who's watching out for this little baby? So on the discharge point, that going back in time, that is a stress point, I think, for providers. And what can we do to help make sure that this baby's safe and do this discharge safely? So the focus program can ease some of that stress point for families. So we will have medical appointments immediately for the baby in the, so immediate hospital follow-up. We can often get the babies in within a few days. And we can establish care with mom at any of those visits. Then we have developmental services, the early intervention program, where we can enroll families at the first visit. But again, look here, I underline the home visiting because we've already talked about that in the chat. Yeah, home visiting is a way for us to bridge that vulnerable time right after discharge, when home visiting services can be established in the hospital prior to discharge or immediately after. And home visiting can be that nice bridge for us where a family who doesn't necessarily need CYFD intervening in their home, but they need some support to ease that transition out of the hospital and to support the parents, just like we were saying, and the baby in that early discharge period. So home visiting is also a really important part of this program. So we talked a little bit about what, at discharge, what do we already know that this family has in place? So the baby is living with the grandparents. They had established with the Hatch home visiting program in the hospital at UNM. So there are lots of home visiting programs. The Hatch home visiting program is particularly integrated with the Focus program because it's some of the same teams who are providing that care. Hatch is a program that serves all of the NICUs in the whole state of New Mexico. So they had met the family at the hospital, and the home visitor was coming the next day after our visit in the clinic. And then what was really comforting was that the Milagro program was in place, and the clinic was right there with us at the same time to do the medical care for this mom and try to assess where she was in her substance use disorder, what treatment she was wanting, because she had tried to initiate some treatment right before delivery or right after delivery and was kind of struggling getting the balance, like Dr. Goudelet had mentioned, that she was experiencing significant withdrawals. And so it was not where it needed to be right at that moment, but she was going to see the Milagro providers. And we were so happy that she came to that visit. And then she looked gray and unwell because she was having significant GI issues and pain related to an undiagnosed GI disorder that the Milagro team had been working up. So just knowing all of that we had the Hatch program was there and the Milagro program was there was reassuring for me at that visit. Okay, this always would mess me up for so long. I could not get this straight in my head. Like, everybody talks about early intervention and home visiting, and I'm like, what's the difference? They're the same thing, or I don't understand what the difference is. So this again is a slide that I borrowed from my friend Karen. So early intervention is more like a targeted therapy that is for delays and conditions that are identified. And it's started for any kids who qualify, and it's started after the kid goes home, after the baby goes home, and does services up to age 3. So it is the directed therapies towards a developmental delay or an issue for a kid. Whereas home visiting is thought of as a preventative service that every single person in New Mexico who has a little baby can get access to. And I think it's so cool that we have that in our state. So it's available for everyone. And there are various providers who do home visiting services. And it's just a really nice, lovely thing that happens right after the baby goes home. I always think about one of my colleagues, Mary Beth Sutter. Her husband was Dutch. And so when they got discharged from the hospital, he's like, well, when does the baby nurse come? Because in Holland and in Scandinavia, they have a baby nurse who just automatically goes to their house and will clean up their house, will like do their laundry and help them figure out how to change a baby diaper, make sure the baby has that little box to sleep in that all the Scandinavians do. So to me, it seems like it's a lovely, like, Scandinavian level of care for babies and families. And so then under those two programs are our two specialty programs. So like the UNM focused early intervention is our team of early intervention specialists that are kind of connected with our team of medical providers. Then there's the Hatch program that I mentioned that serves all the NICUs in the whole state and collaborates with the NICUs, and then can do this sort of handoff of care easily to our focus team. And Hatch program is just one of the home visiting services. I know in the chat we had mention of a few of the other programs. So this helped me when I had this slide. I tell you, I'm still like trying to make sure I'm clear on which team is which, but this really helped me to keep straight what is early intervention versus home visiting. Okay, so now we are coming back to our case here with the family in the clinic. So in our medical visit, we really tried to use our medical team's time efficiently to discuss about the appropriate feeding and volumes and recognition of when a little neonate who still is having some symptoms of withdrawal may be hungry or maybe just wants to have something to suck on. So we tried to do that teaching with the grandma and include the mom in that discussion. And then we also were trying to coordinate with the Milagro team. So coordinating for us means, hey, my goodness, you know that she's here and that she doesn't look well, and just to discuss her case. And then we offered primary care at that visit to maternal grandma. We said, you know, one of the things we can do in focus is we have doctors who could be your doctor. Do you have a primary care doctor to help take care of you, because you're going through a lot here with a new baby and dealing with your daughter's complexities? And she says that she's very connected, and she actually has a therapist, and she felt fine with her care team. And then, but then I'm like, okay, this is like, there's still this sort of volcano. I mean, they were going through like everything in their relationship, all their pain and betrayal and sadness and loss and fears right there in our visit. And we were just supposed to kind of just move on. And so that was a stress point for our team. And I felt like really privileged too, that the family felt safe enough, all of them, to talk about what they were struggling with and what they were going through. So I felt lucky that they felt that they could do that, but still then I didn't know what to do with it. It was too much for me. I don't have the tools. So fortunately, our early intervention team and our infant mental health team are available at the visits. They come to the clinic and are there during our clinic visits. So the infant mental health team actually came in, Karen came into the visit and did a very short intervention and kind of goal setting and redirection of sort of what was happening for this family. So Karen said things like, you guys have talked about a lot. After this visit, you're probably not going to feel better. You're probably going to feel worse. So kind of setting expectations for what it means to kind of have that flood of emotions. And also talked about that this is a lot to unpack and how they have already done some really positive choices for this baby, both of them, but especially the mom, who was really in extremis emotionally, that she had already, she's seeking care. She has the baby in a safe place. She's making decisions that are protecting the baby and keeping the baby safe. So sort of reinforcing her positive choices about safety for this baby. And then, and so it was sort of to have this expert in infant mental health come in and be able to reset the visit in very short, so that we could keep moving, but not to ignore or just pass over all of this emotion that had come up. And then, of course, for the little baby, we needed a follow-up pretty quickly to kind of reinforce and support the feeding instructions that we gave in this fraught moment, to make sure that our message was getting through. And then the EI team, the early intervention team, also came in to enroll the family in EI, so there could be a seamless transition from the home visiting to the EI team. And then mom left that visit with us to go into the other room so that she could get her care with the Milagro team. And what was nice too is I felt like the mom could get her care that was separate and that was private and that was individualized for her from the Milagro team at the same time. And so then the maternal grandma, we set up an appointment for her to get infant mental health and to have therapy, infant mental health therapy ongoing. And then she was going to be seeing her home visiting team the next day from Hatch. So then my sleep was only affected by all the other stuff, which my chihuahuas lately are having nightmares and they have to sleep with me. And then of course the pandemic affects my sleep too, but I felt like, okay, I could feel comfort in knowing that we sort of did what we could to set up this family with services. So I think the key thing about the focus program that makes it work is that there is medical team coordination. So we do a care coordination. So we transition care with the Milagro team. So we communicate and collaborate with the Milagro team. They will do the postpartum care up to 8 weeks, and then they transition that care to us, and our adult care team does the long-term primary care for families, including the continuation of their medication-assisted treatment. And then we have the perinatal psychiatry services, and I think they're some of the most interesting people. I think that would be my second existence is perinatal psychiatry. And so I want to really talk to you guys about this too, especially in rural areas, because with the pandemic, we had to use perinatal psychiatry services remotely. So it actually, in a way, increased our access. I think it's harder for the providers to always be able to do a visit on Zoom, but we were able to set up families on their phones with Zoom, or they could come into the clinic and have a Zoom visit with the psychiatrist, even if the psychiatrist couldn't be there. So there were some things that were good that came out of COVID, and one of them is streamlining and kind of solidifying that remote access to perinatal psychiatry. So I want you guys in communities outside to know that there is perinatal psychiatry. If you're scared, if you have a woman who has a history of postpartum psychosis or significant postpartum depression, these perinatal psychiatrists know how to help and to prevent that. It's really interesting and fascinating and really cool. So that we communicate and coordinate our care with them. And then there are monthly team meetings that happen between Milagro and Focus that where there's case discussion and there's transition of care. And then once a week, having those two clinics together at the same location and time, Milagro and Focus, really helps because we learn a lot about their care, about what they're doing for families, and what the families need and what's going on. The other thing that makes I love my work so much is being able to be with the family medicine providers, because they have a different angle and approach to families. They have a focus on harm reduction and sort of a larger view, whereas I might have a little specialty area of pediatric medicine and pediatric diagnoses and interventions. They help me to take a different view of families and to change my care. So being physically together makes a big difference for our care. And continuing with this sort of theme of coordination is staffing. So the early intervention team, who, they have that transition of home visiting team to EI team. They have weekly meetings where they discuss all of the families who are scheduled in the Focus Clinic that day. And they discuss what issues the EI team, the home visiting team, what's going on with the family, what things they think the family needs, what major developments have happened, major life events, including death of a spouse, including a new job, including successful things, but also really, sometimes we can't all know sort of the severe dramas that families have to go through. And so the EI team has this meeting, and then they summarize it for us. And before the clinic, we have a clinic huddle where the EI team passes their information on to the medical team. We also can go to this EI staffing meeting and be there to have that full discussion. But then at the end of clinic, our medical team summarizes what we've done in clinic and sends that back to EI. So we have a lot of information about these families, and coordinating with the EI and home visiting teams make a huge difference in our care. Then we also coordinate pretty closely with our Child Protective Services and CYFD when there is a caseworker involved with families. And I just want to I think there's myths out in the community that either that we call every family into Child Protective Services or that we never call them. And we call and coordinate with CYFD when we need to. And recently we've had to report families to Child Protective Services. One was a family where there were babies in the multiple babies in the family with complex medical needs, and there was a very abusive partner of the mom who was refusing to allow specialty care for these little babies. And we did call the Child Protective Services, and they did do a home visit, and the family came back into care with us, even though they knew that we had reported them. Then we had this other family who was a long-term established family with the Focus providers and was very connected to our whole team. And I think because the mom felt very secure with us, she disclosed something that we were worried about, that she was staying up all night by herself in the apartment with a toddler and using methamphetamines all night long. And so it was a very fraught situation, because she felt safe enough to disclose this use to us, but it also was alarming for the safety of the child. And we did call in a report, and they did do a visit with this mom, and it did cause a fracture in our therapeutic relationship. But I think last I heard, she is still bringing her child for visits, and we are trying to mend the visit and frame it for this family. So then, when we think about this program, we're growing, and we want to be able to sustain a program like this. We can't be dependent on one provider or one person. This program was designed by my mentor, Dr. Shi, and he has retired. So as he has transitioned out of his role, how are we, as this, Focus 2.0 providers here, what are we going to do to sustain it and make sure that it doesn't go away if we aren't there? How can we make these components lasting and be able to recreate this program in other places? Like, we cannot all have an Andy Shi in our community, so we need to be able to take this model and transplant it in other places. So what are the key components of it? We know that the other part is that we cannot be siloed. We can't just be named the focus program and it's a focus program and that's it. We have to reach out and to communicate and collaborate with all of our other programs in the community that provide services. And I was really focusing on the pediatric side of this. So I meet and talk with the child abuse team and with the foster care kids clinic, the Healthy Beginnings clinic. I collaborate with my colleagues in the NICU. I also will call up the emergency room and say, you've got one of my families from the Focus Clinic. We have not been able to draw the HIV labs on this little baby. Can you please draw those labs in the emergency room? And they did that. That was really fortunate. And then I'll work in the pediatric urgent care and provide care for our families there. And then also being able to call up and talk to the pediatric specialists. So the more that we reach out and communicate and bring in the other specialists, the better we do. So that is one of our guiding sort of goals lately, is to really continue and sustain our communication with the other teams. So if I was going to say, okay, community in tiny area outside of Arizona, which is what I was just talking with Banner Health. There's a little family medicine clinic that's just outside of Phoenix. And they're like, we want to do the Focus program. So I'd say, okay, well, obviously we have a lot of resources. We have all these teams at UNM, but what would be the key elements so that we could have a Focus program in this little tiny place outside of Phoenix? It's really nice to have pediatric and adult care together. And that is really nice with the family medicine model, like family medicine providers can do it, but it could also be a collaboration between a pediatrician and an adult provider. It's really great if we're there simultaneously so that the family comes and they can get all their care at the same time. Because like Dr. Goudelet is saying, it's really challenging for families who are experiencing the challenges of substance use disorder to get to multiple visits. And then it's so nice to have, for instance, perinatal psychiatry or other specialty care available. And I would say that telehealth is going to be our secret to disseminating that out and to have access for other communities. And then the other thing is to reach out and talk with your developmental and home visiting services. Can you have a regular meeting with them? Can you just have a phone conference with them? Can we have this communication between these two teams? Because I think that is one of the best things that we do in Focus Clinic is we get this whole picture of how a child is at home, what challenges a family's facing at home, what services and medical care they really need, and how can we bring that in. So I wanted to kind of step back and talk about actually who we have in the Focus program. And so we have about 250 families that are currently enrolled in the program. And again, our program is designed to be the place where families with a new baby or young children can come when they have structural determinants of health. So we sort of are known to take care of families where there is opiate use disorder, but that is, or a baby with prenatal opiate exposure. But that's not the only group of families that we serve. We also serve families with young children with just the structural determinants of health. So teen moms that are unsupported, or parents with mental health needs, complexities of incarceration, housing instability, parents with development and intellectual delays who have various levels of support, or kids in foster and relative care. And these are just some examples. So when we're talking about stress points, I have a panel of patients that I see. I want to say regular, but that's not a good description. I have a panel of general pediatric patients that I see in my clinic. And I had this mom who had developmental delays. She was pretty high functioning. She could have a job and drive, but she would yell all the time. And she was really loud, and she would just yell and cuss. And she wasn't angry. That was just the way that she communicated. And then she also just seemed sort of disorganized, and it was hard for me to communicate with her about the care of her baby and feel like she was really taking it. So the baby would cry when the baby was little, and she would give the baby a lot of Tylenol, and so it was very stressful. So it was like this point where I'm like, oh my God, I don't know what's happening here. And this is a family that I transitioned over to the Focus Clinic, and our EI person had made a lovely relationship with this mom and was able to give her a lot of support and just help with these sort of questions about baby care and how to communicate with babies. So there are other families, not just a family dealing with a substance use disorder, who can come to the Focus Clinic. We have a teen mom who was she was in foster care when she got pregnant at 15. So we take care of both her and her baby. So that's another interesting family that we take care of. Okay, do you want to refer a family? Is this family in one of the 3 counties that we serve? Keep in mind that families can access the services in Focus Clinic kind of like a menu. They can take, okay, I'd like speech and massage, and I'll have baby care, but not mommy care. So just like a menu, they can kind of choose anything off of that list that I showed you with those 2 circles. So they can keep their own medical home outside of the Focus medical home and just get the intensive EI and developmental support, or they can flip it. It works both ways. We are currently expanding our developmental services into school age up to we're doing age 5, and then we transition kids to school services. So we just got a grant to expand our developmental services, but we also are not asking families to leave our medical home setting if at a certain age either. It depends on if it's a good fit for families. So we'll keep families in the medical home up to any age. So here's how you can refer families. You can refer them to families, and then we can work with the family to decide if they want to come to Focus Clinic. And so Power Chart, or there's the Focus phone. You guys can just call us. We have a referral form as well, and this can be part of a CARA plan. And then if you want a medical appointment, again, you can call up the Focus phone. Those are the times and days when we are holding the Focus Medical Clinic. And so if that will work for families, we try to go where families are. So we're at North Valley and Southeast Heights in Albuquerque. So I want to come back to the case that we talked about. So we did those interventions for the family. So at the next visit, a week later, the mom and the grandma and the baby came. The baby everyone felt like they were much more comfortable with the feeding plan for the baby, and the whole appearance of the baby was better. He wasn't topping off with those giant volumes. They gave a little bit smaller, more frequent feeds. The mom looked a lot better at that visit. I'm not sure why. I, I think maybe she was getting some treatment for care. Maybe she was in withdrawals at the first visit. She looked better. She was more clear. She and her mother were communicating better. It was a much more relaxed visit. And they were really happy with the home visiting. The grandma really liked the home visiting program and got a lot out of it. So we scheduled another visit for the next week. At this visit, the grandfather came, and he is just in love with his little grandson, like just really, really likes him. They had started the infant mental health treatment. They had their first visit to kind of get that therapy started. Meanwhile, mom had reunited with her partner where there was concerns about intimate partner violence, and so he's sort of a challenging figure in the family. So there was some conflict with the grandparents, and that's where we left off. So I think we have a visit next week, and we'll see where everybody is and see what we can do for everyone at that next visit. But so far, we're doing okay. And I think that this family also really encapsulates the challenges where we have to accept families where they're at. And although we'd like to control and fix everything, we can't. We have to do our best where families are. Okay, so now I want to completely change gears, and I have a request for everybody in the audience and an offer. So Kathy mentioned when she was describing what work I do, I do this focus clinic, but then I also have created an education program collaborating with colleagues at Press and with experts at UNM to create an online curriculum to help optimize care, the inpatient care of babies with NOWs. And I thought it was so cool that a lot of the questions that were in the chat for Sevi's talk were exactly questions that I cover in these modules. So, and these modules are not about Eat, Sleep, Console or about Finnegan. They're kind of just the background, I think, that everyone needs to know about taking care when you have a neonate with opiate withdrawal. What happens prenatally, pregnant women, labor and delivery, what's going on with the mom postpartum, and then what's happening with the baby in the hospital, including breastfeeding challenges, then assessing the baby and what kinds of treatment are best for the baby, and a big section of that is non-pharmacologic care. And then we have a piece about the focus clinic and an introduction to Eat, Sleep, Console. So it's like a supplement to whatever management system you have in your hospital for babies with opiate exposure. And then I got a grant to make it all smooth and make a fancy production of 2 of the modules. And so now I need your help, because I need to know if they're okay and what they are like and what problems there are. So I'm looking for an audience to look at them. And I have an offer. The first 20 people who sign up, and this would be nurses or any other providers, and I'm especially looking for folks who are rural providers. I have a $100 gift card to give you. So this is kind of what the modules look like. I love that painting. That was done by my son's girlfriend, Issa, when I described the program to her. I think it's so sweet. And so here's what it would be. You guys would watch 2 modules, and then you would take some surveys, and we give you a $100 gift card. And so I really need your help. So please, you can click on this link on the slides there. The slides are going to be in they're in the resource page. And then now I'm going to paste in the link in the chat. There's the link in the chat as well. So if you click on that link, you give us your email, then we can enroll you. So I hope that you guys will consider signing up and helping me out with this. And so now I am really happy to go through some of the questions. Brenda, do you want to tell me or Kathy, do you want to sort through the questions for me? Because I'll get
I will.
dysregulated if I try to read them? Or,
I will be more than happy to read them for
okay.
you. So the first thing I think Jillian, who I think might actually work for Focus, says during COVID, all visits are loaded with grief, substance abuse, and anxiety. I guess it's been a very tough time for you guys.
Yes, yes, it's been, yes, it is. Yes. So we all try to do again, I think having the support of the different providers and teams so that we can overlap, we can share that, like the stress of that family, I could spread it out, right? And not just have it be just on me and that visit. And Kathy, don't you think that that's what providers, like when we're in these settings, we take it like we have to
Yes.
fix it all the time, right?
We do. We
Yeah.
do. Tina says, what role do you see for or utilize MCO care coordination?
Oh yeah. Yes. I'm so glad you mentioned that. Yeah. Who is that?
Tina Ross.
Oh yes. Tina, how's it going? Long time no see. Yes. Care coordination is an excellent, fantastic supplement. And I wish I would have put that in. I'm sorry that I didn't put that in. It has been, we've, since the CARA plan and the increase in the care coordinator role in this, there's the care coordination has been a fantastic supplement that really helps out with families. And we so appreciate the care coordination from the MCOs like Tina does. So they, one of the things that we need to do is we need to make sure that families know that care coordination is going to be offered to them. So yeah, I need to put that somewhere in there. So when you're talking with families who have complex pregnancies and who have opiate exposure with their babies, tell the families when the care coordinators call them to accept that service. Because if they accept it, the care coordinators can be just a fantastic resource for families. So thanks, Tina.
Jill asked, does Hatch cover all NICU babies or just babies with substance exposure?
No, every NICU baby. Yeah, in the whole state.
All right. And does the CARA care plan, and how does the CARA care plan fit in?
Yeah, the CARA plan is it's a way that so the CARA plan is very complicated, and so the CARA plan helps us to kind of identify what needs the family has, and the discharge to services set up by the focus team can be part of the CARA plan. So the CARA plan is part of the way that families can access focus and access other services. You know, I could do a whole dang talk about that CARA plan. It might be good. You know, I think we had the CARA plan folks at the last time we had this conference in person, and it'd probably be good to have them come back around again.
I think so too, because they had just initiated all of that, I think.
Yes, time. Right.
Sarah says, do you have an integrative medicine provider as part of your team?
Well, not necessarily an integrated medicine, but we have baby massage and some of the alternative kind of holistic supports for baby. But no, we don't have specifically an integrative medicine person. It would be super cool to have those services as well. Okay, so yes, so let's do it. You know of one? You want to come and do it in focus? Come on over.
Alicia says, for a baby to get infant mental health, do they have to be in the focus program, or is that something that we can make a referral for if they're not in focus?
Right. The infant mental health team works out of the Center for Development and Disability. So you can put in a referral to the Center for Development and Disability, and they can help you get access to the infant mental health services there. There are other infant mental health providers in other communities around the state. Taos has a really robust infant mental health team, but I would start with the CDD because they would have the resources for accessing them.
Let's see, what else is there? Is there any specific criteria that needs to be met to be referred to focus?
Really, no, it is the we serve families who have structural determinants of health, and I like that structural determinants of health instead of social determinants of health. It just sounds, like that's what Alfonso Belmonte is using. So really, that fits almost everybody in New Mexico because poverty could be one of the criteria, and so I think it's a family that has needs that go beyond just a straight primary care. So if I tell you, if you get a little tummy ache when you're taking care of a family and you're like, oh my God, I need some help, that should be our focus criteria, is provider tummy ache.
That's a good thing to talk
Yeah.
to say. Is methadone or morphine the preferred first line now? It seems like we've been using both between the NICU and our step down units.
Right. It's you can tell, I think that was from Matt. He was asking, Matt, we don't have the data, right? I mean, I think that's why we're trying to do these large trials. There are some studies that support either one. And what I think we're going to figure out is that the best treatment is non-pharmacologic care. And we're asking the wrong question. Like, is morphine or methadone better? Is the wrong question. I think the question is, how can we maximize the care setting for babies and for families in terms of non-pharmacologic care? And then secondarily is identify the babies who have the genome that puts them at high risk for withdrawal. There's those certain cytochrome P450 enzymes that are fast processors, or all that stuff. So it's going to be that combo.
Jasmine asks, if we have a baby that may qualify for the focus program in the NICU, can we call and see if they can get a follow-up PCP appointment as a beginning step? And what about families from other communities?
Yes. Yeah. So certainly they can come to the medical visit and see if they want focus. Some families are like, I just don't need it. It's too much. I can't do it, or it's just not the right time. So yeah, for sure. And then for families in other communities, we don't want moms to try to commute from Socorro or hours away to come to these visits. But what we'd like to do is if there are communities who would like to talk to us about how we do our work in focus, we'd like to support you in doing that. And so get in touch with us and we can work on it. I see Tina's question about identified as the PCP, and that's one of these stupid technical questions where we're trying to work to make sure that we can impanel patients in focus. So yes, the focus can be identified as the PCP. We are the PCP, but it's sort of weirdly designated in the EMR and other places. So we're working on that.
Then I just have a quick question about, you mentioned that the patient that you were talking about, that she had started with her partner, there might be intimate partner violence. So how do we go ahead and approach the whole family, to help? Is there any mechanism to bring the dad into that situation so that we can go ahead and maybe address his concerns and his mental health issues?
Totally, yes. So I didn't include actually in that little thing that at the visit with the grandfather, the dad had come in, he wanted to see the baby, he hadn't seen the baby, he came in briefly and then left. And so, but we tried to be welcoming to him and to ask him if we could help him with care too. So yeah, we have families where we've helped dads and other relatives try to get into recovery and care and to improve their circumstances as well. And I think that's an interesting question about the Fathers New Mexico program. That'd be a good group to get involved with too.
Okay, does anybody else have any other questions for Heather? All right, Heather, thank you so much for the talk. You guys were great. I think you gave us a lot of really wonderful information. And I think it's really helpful for us just to go ahead. We see a lot of, we see our babies in the NICU, in the nurseries, at the time of delivery, and we all worry so much about
Yeah.
these families and
Yes,
stuff.
totally.
So it's really great to be able to know what is out there for them, and that we're trying to go ahead and expand our services that we have in the metro area, trying to get them out into the rest of the community. And so I'm going to give a little plug for all of us here. If you're interested, if you're in your community hospital, if you're interested in learning more about this, would like to have a more directed conversation with Heather and Sevi about what you guys can do in your communities. They're also partnered with Presbyterian on these type of situations. We will be more than happy through outreach to set up those type of classes. We can do them through Zoom until the pandemic gets better, and then we can expand out to having some really good contact with you. So please feel free to contact the outreach program about that, and we'll go ahead and work on that for any community in the state of New Mexico. So thank you guys so much. Thank you, Heather.